In this section, we're going to go over some sample OB triage management case studies and some recommendations for midwives, nurse practitioners, healthcare providers, and how they will implement ultrasound point of care services within their triage management, whether it's the clinic setting, hospital. These recommendations are going to be very similar. Just depends on the resources you have available with your facility. So the first case study, we're going to talk about someone that comes in with early pregnancy bleeding. This is a 28-year-old woman presents with vaginal bleeding at 7 weeks gestation based on her last menstrual period. No previous ultrasounds have been obtained. She's accompanied by mild cramping, but no severe pain or passing of tissue at this time. Her pain is more generalized. She's not talking it's on one side or the other side or severe or sharp. She's just having mild cramping and wondering if this is normal. The bleeding she's having is more of a spot, older discharge bleeding versus bright red, new, increasing with time. So some of the things you want to think about anytime there's vaginal bleeding with pregnancy, you want to make sure that the pregnancy is still viable. Depending on at 7 weeks, you should be able to see a heartbeat, fetal pole, do some dating measurement, do some serial HCGs, further evaluate where's the source of the bleeding coming from. You want to rule it out if it's from inside the uterus. Is it coming from the vagina? Are there other sources of bleeding spots? The ultrasound findings note a transvaginal confirms there's a viable intrauterine pregnancy. The fetal heart rate's approximately 160 and is measuring appropriately for 7 weeks gestation. You do note a subchorionic hematoma underneath of the placenta and recommend further evaluation, and that's most probably where that spotting and bleeding is coming from. You want to make sure that the patient gets follow-up ultrasounds, whether in a week, giving reassurance of the baby and what to watch for to call back the clinic. Close monitoring. You can decide to do serial HCGs until 9 weeks gestation. You can just have the patient do bed rest, limited activity, rest and reassurance, drinking lots of water, taking care of themselves, and then keep a close eye on the progress. The next case study would be ruling out ectopic pregnancy, which is a medical emergency if that is truly occurring. You have a patient that presented 32 years old, previous history of an ectopic pregnancy, which puts her at a higher chances. She's having abdominal pain, specifically on the left lower quadrant, and some vaginal spotting. She's approximately 6 weeks gestation, and the pain had gradually been building but gotten very severe and came into the ER to be evaluated. Depending on your facility, many of these will be the midwife, the practitioner in the ER that takes care of this. Most OB triages don't start evaluating up on labor and delivery units until after 20 weeks gestation. This may be a patient that had an appointment with your office, but most likely they're going to come into urgent care. You want to do quickly a transvaginal ultrasound to determine where the pregnancy is located. You've already done a urine pregnancy test. You're confirmed that the HCG level, she's definitely pregnant, and you're not actually seeing a gestational sac inside the uterus. You're not seeing heartbeats. You can decide based on your skill level at that point if you get the obstetrician involved right away, you get the ER doctor. If you can get a sonogram with the department quickly to rule out is the pregnancy within the fallopian tubes. Are there any gross anomalies, free fluid situated that could help determine where the pregnancy is actually located? Just because you can't see it inside the uterus, it may not be viable. Her dating may be off, especially with the pain and how it's located. You want to rule out ectopic pregnancy first, since that's a medical emergency. And then if you get the specialist, the collaborating provider, the sonography department to confirm there's no ectopic pregnancy present, then you start ruling out other things. You want to really take this as a medical emergency, just the same as when you do for heart attacks, strokes, vaginal bleeding, pelvic pain, especially ruling out ectopic pregnancy as a medical emergency and needs to be taken appropriately so you can avoid the complications of a potential tubal rupture. Case study 3, this one has to do with someone presenting for late pregnancy and you want to confirm the placenta location. This person may or may not have a history of established care with your practice. You may or may not have records of prior ultrasound reports. You're just basing it on she has came in to the triage having decreased fetal movement. She mentioned she may have a low-lying placenta. You want to confirm where it's located, how's the blood flow, how's the growth on the baby. Typically with decreased fetal movement, you're going to do a non-stress test first. So depending on what the results of that are, it's definitely good if you're worried and need further evaluation, especially if the non-stress test doesn't come back reactive, reassuring. You would want to do a biophysical profile. You'd want to check a fluid level. You would want to evaluate the placenta's location, the grade levels, how much calcifications. There's a lot of different things you can get to help with the fetal well-being based on the ultrasound machine. Case study 4, fetal presentation. This one is a more common thing that midwives and healthcare practitioners, when a woman comes into labor and she's had a history of breech, unstable lie, you can't confirm based on a vaginal exam or Leopold's maneuver the baby's presentation. It's really a common way to just do a point of care ultrasound and quick check baby's position. Check is what's presenting in the pelvis, what direction is baby head down, LOA, OP, how much fluid is around the baby, are there any gross anomalies, is there anything quickly you want to get, especially if you're ruling out rupture of membranes, getting that presenting part, checking a couple fluid level pockets. If it's less than 5 and she's leaking fluid, you got equivocal results from your amnisure, burning, nitrazine. It's great just to grab the ultrasound to actually confirm presenting part and the fluid level. So based on the findings, the fluid level is normal, the placenta was great, the baby's head down, you would expect an uncomplicated vaginal delivery if there's no other history to be worried about. So it will make a difference in your immediate decision making versus you have to wait for results or you're kind of nervous and anxious, like, okay, until the baby's lower in the pelvis or these tests come back, you're got answers and can improve your management quicker. Case study 5, this has to do with assessing fluid growth restriction. Depending on how your triage, your protocols, your scope of work as a midwife or healthcare practitioner, this may be a routine monthly growth ultrasound with the sonography department, but we're talking about this person has had a history of fetal growth restriction. Maybe they didn't show up for their last few growth ultrasounds and they ended up in triage for you. So being able to confidently get the parameters, the abdominal circumference, the biparietal measurements, and the metrics for the growth ultrasound are essential to know if the baby has overall parameters in that 10th to 90th percentile. What are the trends? What are the last reports been showing? And it's also a good idea to do that non-stress test depending on this patient's 34 weeks gestation. So it's very appropriate to do a non-stress test, a biophysical profile, growth ultrasound, depending on how urgent your situation is and the next plan. Are there other comorbidities? What is potentially causing the growth restrictions? Are they on drugs? Is there stress in their life? Is there poor nutrition? Is there a history of implantation issues with the placenta? Does she have a history of growth restrictions with her other babies? Is she have preeclampsia? What are other things that could potentially cause the umbilical artery blood flow to be decreased that would be impacting the fetal growth? Is it symmetrical growth restriction? Is it asymmetrical growth restriction? Those things will make a difference on determining pathways and working closely with the obstetricians, maternal fetal medicine. Are you going to do a close follow-up the next day in the clinic? Are they going to stay on the antepartum unit depending on the results and findings? This one is a normal. There's no evidence of growth restrictions or compromised blood flow. The non-stress test was good. The biophysical profile was good. The recommendations would be to follow up in 1 to 2 weeks with that patient's prenatal clinic office and then come back to the urgent care if there's decreased fetal movement, vaginal bleeding, routine OB precautions that you would send them back to triage for. Case study 6. an evaluation of polyhydramnios where the fluid level is above 25. This is a 25-year-old woman that presents with 38 weeks gestation, has a history of poly, and is here for a routine prenatal visit. They were able to get her in for the sonography, which is happening with shortage of staffing, and you would like to just check the fluid level to see if it's gotten more significant. You've already ruled out kidney issues, problems with the baby, she's drinking well, the placenta is working well. So you want to do a good biophysical profile or just the fluid level. So checking all the pockets, getting a measurement, depending on your competencies and skills, having someone else check and making sure. There's really nothing specific with polyhydramnios, just by giving the precautions of if she goes into labor, her water breaks, she's a higher chance of prolapsed cord, a higher chance of baby not being in the greatest position for labor just because there's so much fluid. So you really want to have good conversations that this would be a patient that would come to OB triage and early signs of labor, vaginal bleeding, fluid leaking, movements of baby more than the average person just because of so much fluid when the water is breaking. Case study 7, suspected preterm labor. You have a patient that came in, 30-year-old woman, 30 weeks gestation. She has suggestive signs of preterm labor. She's having contractions every 2 to 3 minutes. She's having a lot of pelvic pressure increasing with time. The contractions started 12 hours ago. They've been slowly getting closer and stronger. She doesn't have any vaginal spotting at this time, no abnormal vaginal discharge, hasn't had sex recently, no new stressors in their life. There's no obvious signs of what could be causing this preterm labor. So you're going to want to do a fetal fibronectin. You're going to want to get the baby on the monitor. You're going to want to do a vaginal exam or a speculum, depending on how concerning her symptoms and how she's acting with her pain. And if obviously there's an urge to push, you want to make sure that you're just taking highest priority. So this lady is just acting more uncomfortable, but doesn't look like she's imminently delivering. Getting a cervical length is really helpful. It's hard to know when there's not a baseline, but at least it's more information. You're noting there's funneling, there is an intact membrane, and there's no cervical dilation. So you want to make sure this person is getting fluids, resting, giving some Tylenol, waiting for the fetal to fibronectin, maybe reevaluating in 2 to 4 hours, cervical change, maybe repeating that cervical length. Getting obviously the obstetrician involved because it's threatened preterm labor, but you could be that initial point of contact, especially if it's a busier unit in triage, to help get things initially established. There's a good probability that that patient's going to stay with you or is going to be shipped out to a higher acuity facility, and you just need to prepare getting the meds ready for threatened preterm labor, depending on surfactant and considerations of tocolytics and therapy to help improve. Obviously, perinatal services are going to be involved. You're going to have a joint effort to try to stop the labor. And if you can't stop the labor, you want to prepare for a preterm delivery. And so depending on how urgent things are and how imminent they're delivering, it may not make the most sense to get a point of care ultrasound on this patient, but we're just talking hypothetically. These are some of the things you could do to consider with point of care ultrasound implementation. Case study 8, evaluation of postpartum hemorrhage. This one, a lot of obstetricians will use it for point of care. I don't see too often nurse midwives utilizing it to confirm if there's any retained placenta parts, but it's definitely important to know you can as a tool. So we have a 28-year-old that presents. She's had a delivery about 4 hours ago, and the nurse calls you at postpartum, and she said there's a lot of increased vaginal bleeding. You do a manual, you give her Pitocin, you give her Cytotec, you do postpartum hemorrhage management, but there's just this slow, steady trickle and you keep getting clots. The obstetrician is most likely involved at this point. You may be helping the obstetrician with the point of care ultrasound to confirm, are there any retained placenta parts that they can't get out with manual and with using instruments. They may have to take them back to the OR and be able to visualize and be able to do it under general. So this is more of a higher risk obstetrician component, but you could, if you're a lower acuity facility, the obstetrician's not around, it's maybe not a significant emergency situation where you're having to do by manual, but you want to confirm that there are no retained placenta parts and you can't send them down to the sonography unit right away to get that evaluation. This is a great way for a point of care ultrasound to be implemented postpartum. Case study 9, an assessment of placenta position in a woman that's had multiple babies before. She is 36-year-old multiparous woman, presents at 32 weeks gestation with occasional vaginal spotting. And the past ultrasounds have shown a normal placenta, posterior position, no low lying, but it's always a good idea to double check. You want to confirm, where is the bleeding coming from? Is it coming from her cervix? She recently had sex. It's spotting. It's old blood. It's new blood. Is it coming from the placenta? She's had a history of low-lying placenta. She's had a history of a partial abruption. You want to know what is going on and get the source of where the bleeding is coming from. So you're going to want to do a non-stress test, a biophysical profile, potentially a growth ultrasound, amniotic fluid levels, placenta location, plus is there any bleeding around the placenta? See if you can use the ultrasound to determine the location of where the bleeding is coming from. Case study 10, evaluation of suspected oligohydramnios. You have a patient that's presented 29 years old, 36 weeks gestation with decreased fetal movement. She's had a history of lower fundal heights, and so they've been watching her closely, and now it's Friday night, and she's worried about her baby. She's already drank some juice. She's already done the things she's supposed to do. You want to have her do a non-stress test, and if the findings are good with a non-stress test, most likely you're not going to do a biophysical profile and a fluid level. So we're going to assume that the non-stress test was not reassuring, and you're going to do a transabdominal ultrasound that notes decreased fluid levels less than 5. You're getting 3.8. And then you're also doing a BPP, a biophysical profile. Potentially, you could be adding a Doppler assessment depending on her history and situation. It's a little higher acuity situation and more skills involved, but it's possible. The biggest thing is you want to know, how's the placenta function? What are potential causes of that decreased fetal movement? Is there any vaginal bleeding? How's the placenta doing? How's the overall function? So you know that there's oligohydramnios, and you determine at 36 weeks gestation, you're going to give her some fluids, you're going to rehydrate her because she hasn't been drinking much the last couple days, and you're going to repeat that fluid level in 6 hours, 8 hours. You may or may not decide to have her go home. The baby's starting to move better. She really wants to go home. She has 5 kids, no babysitter. She's reliable. She can come back. Or, she hasn't gotten much prenatal care and the unit isn't super busy. It might be wise just to have her hang out overnight, keep an eye on baby, do that continuous fetal monitoring. It just depends on the resources of your facility, the staffing, the patient situation to determine if you're going to have them stay for continued monitoring, repeat that fluid level, and then make a decision. Does this person normal healthy? Do they have preeclampsia? Are there other co-founding factors that will make a difference of your decision making? She has a history of fetal growth restriction. She has a history of a demise at 36 weeks. You're going to be far more aggressive with your decision making based on unique history situations. So it's not just checking the fluid level, but it's looking at the overall picture, talking to your obstetrician, your high risk team, and making a decision together. Typically, the midwives in this situation are the initial point of contact, get the information, pull everything together, and then talk to their chain of command team. So case study 11, evaluation of suspected fetal malpresentation. This is a 31-year-old woman that presents at 38 weeks gestation with a history of breech presentation on a previous ultrasound. They tried to do a version. It was successful, but she came into triage because she's worried the baby is flipped overnight and she's starting to feel signs of early labor and really wants to make sure that baby is head down. So this is something very simple you can do. You do a non-stress test, you make sure there's no other concerning symptoms, you grab the ultrasound machine, and you confirm baby's position. Yep, it shows baby flipped overnight and the fluid level's good, the biophysical profile is good, there's no gross anomalies. You're going to get the physician involved, especially if she's in labor and contracting. Does your facility do breech deliveries? Would she be a C-section? Would they try to just give her some fluids and watch and wait? Would they try to do a version at this point, depending on how engaged baby is in the pelvis? So your job as the nurse practitioner midwife is to confirm, yep, baby is still breech, get the paperwork started, get maybe an IV started, get the non-stress test, the information, their history, the data all in the system, and then get your obstetrician colleague involved. Case study 12, an assessment of suspected unexpected twin pregnancy. You have a woman that came in for a new OB visit at 10 weeks gestation with a history of infertility treatments and is having a rising beta HCG level now, and baby is normal healthy pregnancy and coming in for establishing care. So you do an ultrasound because the fundal height is measuring about more like 15 weeks gestation versus 10. The Doppler, you get one heartbeat, but just because she's measuring so much bigger and you've got really good accurate dates because of the IVF treatments, you get two beautiful heartbeats and two gestational sacs. So you're going to want to, depending on the scope and the practice guidelines, you're going to want to determine, do the midwives co-manage? Do they transfer care? Keeping a close eye long-term on transfusion syndrome, preterm labor, getting closely involved with maternal fetal medicine on this patient's long-term pregnancy management recommendations.